2-minute anaesthesia, pharmacology, pharmacodynamics, management of post-operative nausea and vomiting. Broadly speaking, there are 6 drug classes which can be used in the management of PONV. These will be discussed individually. First of all, dopamine antagonists. This is a diverse range of agents with 3 subcategories: phenothiazines, i.e. prochlorperazine, chlorpromazine, bupyrphenenones, droperidol and haloperidol, and finally metoclopramide. The receptor modulation of these drugs is diverse. For example, chlorpromazine modulates dopamine, 5-HT, muscarinic, and alpha receptors, and in the past it's been used for management of psychosis. In comparison to domperidone, which is a more selective agent, it'll have a significantly greater profile of side effects. With regards to the use, metoclopramide acts directly on the GI tract and therefore it's superior for GI-related PONV in comparison to domperidone, which does not readily cross the blood-brain barrier, and therefore, even though it's a dopamine antagonist, it can be used for patients with Parkinson's disease. The classical side effect profile of dopamine antagonists include D2 blockade for extrapyramidal side effects, NMS, and increased prolactin, and based on the receptor interactions, it can also cause anticholinergic and hematological side effects. Next is antihistamines. This includes cytosine. This classically causes tachycardia and pain on injection. 5-HT3 antagonist on ondansetron causes QTc prolongation at higher doses and bradycardia, in addition to serotonin syndrome. Steroids will be discussed in a later lecture. NK1 antagonists, including apreptin, can cause significant hypersensitivity, headaches and dizziness. And finally, anticholinergics like scopolamine can cause anticholinergic side effects. Nausea and vomiting is controlled by the vomiting centre. This is a collection of cell bodies in the dorsal lateral reticular formation of the medulla. It has inputs from the CTZ vestibular nuclei higher centres in the GI tract. It contains M3 and H1 receptors. There's a range of different receptors throughout all these pathways, as we're going to discuss, which can be modulated by the drugs on the last slide. The CTZ is a group of cells close to the area postrema on the floor of the fourth ventricle. It lies outside the blood-brain barrier, allowing exposure to water-soluble chemicals in the blood and CSF. It is rich in D2 and 5-HT3 receptors. Triggers at this point include opioids, anesthetic agents, and chemotherapy agents. Higher centres can induce vomiting by both sensory, i.e. sight and smell, and psychological inputs, i.e. anxiety and memory problems. The labyrinth and vestibular nuclei contain H1 receptors. Triggers include middle ear disease, surgical interventions, or motion sickness. The GI tract contains NK1, 5-HT3 and 4 receptors and M3. It has inputs to the nucleus tractus solitarius from the vagus nerve, which directly modulates the vomiting centre. Triggers include toxins and bowel manipulation distension.